So these are the aims of the talk, to discuss why it's so important to look about normal and abnormal bladder function and how that can be assessed, to remember about the relationship of the lower and the upper tracts, and then to consider the question of when to transplant, before or after, maybe doing some intervention, and a little discussion about positioning of certain things such as a Mitrofanov. So as Francis showed, and he showed a better slide than mine, about 30 to 40% of children, and perhaps even more, have got some abnormality with their urinary tract as the cause of their renal failure. And for this reason, it's important. And this was a slide that we put at our British Transplant Urology Society meeting last year that was tweeted endlessly. But I think there's an important message in this. And when we looked before at those conditions where we know that there's recurrence of disease, such as atypical HUS, those sorts of things, we must remember that if we don't correct the bladder and we don't correct it the first time and we still haven't corrected it, it will keep on affecting the future kidney transplants that we put in. So what's a good bladder? Well, the kidneys make urine, and the bladder has to be the receptacle of that. And the bladder should be low pressure, it should be compliant, and that's a different compliance to the compliance Francis was talking about. It ideally should be sterile, and then it's helpful if the bladder is also continent as well. Now, measuring bladder capacity in children is dependent on their size, their age, and their weight, and a number of formulae have been put together. Some of you will be very familiar with these formulae, but they have been standardized by the International Children's Continence Society, and it's very easy to calculate. But at some point, as children, we go through potty training, and we learn what is important in also trying to understand when it's socially convenient to go for a wee. And when that happens and it's socially convenient to wee, we need to think a little bit about something called the bladder or the voiding cycle. Now, if you go for a wee, let's say 6 times during the day, and you wee maybe an average amount of 200-300 mils, and you wee in 20 to 30 seconds, just put that together in your minds. That means that at most in a day, you actually wee for 2 minutes. And you don't wee at night, most of you. I'm getting older, maybe I might. Which means that for most of the day, so we're talking 23 hours and 58 minutes of the day, your bladder has to be a low-pressure, compliant, continent reservoir. And the mechanism which keeps you dry, your external urethral sphincter, has to remain active throughout that whole time. That's one of the most amazingly high-tone muscles that there is within the body. And this needs to be completely coordinated such that when you go for a wee, the sphincter can relax and the bladder can contract without any problem. So there needs to be some sort of control to all of this. And that control is actually centralized within the pons, within your brain. And the mechanism is fairly complex, but it basically relies on your thoracolumbar and sacral spine. The external sphincter has its own nucleus, ONAS nucleus, quite unique for a muscle of that type, to have its own nucleus within the spinal cord. And the coordination between your brain, between your eyes, seeing where a toilet is, your frontal lobes, knowing when it's socially convenient to go for a wee, and the pons, together with your spinal cord, allows this to be coordinated properly. Now, this is the compliance which is different to the compliance that Francis was talking about regarding taking your tablets. Compliance of the bladder is about stretchiness of the bladder, such that as the bladder volume increases, the pressure within the bladder should remain low throughout voiding. And then when your bladder contracts, you get a high pressure with the contraction. But there are some bladders which are dangerous, which are poorly compliant, and those bladders, during the end fill, usually during the end fill, have a very rapid increase in the bladder pressure. And if that pressure is over 30 centimeters of water determined at urodynamics, then we know that that will definitely affect the upper tracts, whether native upper tracts or a transplant kidney, and is a dangerous bladder, a hostile bladder. So assessment of these children, I would say, is complex and needs to be done in coordination with the nephrologists, often with reviewing previous operation notes, the notes in their entirety, and really trying to understand. Sometimes the history comes from the parents more than from the notes, because children have often been at different hospitals. But that's really key to this. And then, ideally, you should examine the child and examine the urine. It's often helpful, particularly in the older child, to get the child to perform a fluid diary where you collect from the child how much they're drinking, what they're drinking, when they go for a wee, and when they are continent or incontinent or have other symptoms. It's also been mentioned by Maria that the first line things to do are non-invasive ultrasound of the bladder to ensure emptying, an ultrasound of the kidneys, and ideally a urine flow rate in the older cooperative child. And then other special tests such as video urodynamics and cystoscopy are often needed. But when putting together the whole picture in preparation for transplant, I think it's really important that the urologist and the transplant surgeon are able to put together things such as the decision as to where the vascular anastomoses are going to be, where the transplant is going to go to help coordinate ideas in terms of any future treatment or augmentation, for example, that is needed of the bladder. And we're going to hear in the next talk about the psychology of transplantation, and the psychology of the child who has to deal with a complex urinary tract is very important as well. Well, these are the cheapest urodynamics, basically a bucket and a stopwatch. And in a flow rate clinic, you really want to make the child feel relaxed, that there's no pressure, plenty of time, ideally somewhere where they don't feel that other people are listening in from the outside. It can be a little bit off-putting. In an ideal world, a single flow rate is not representative, but if you can get more than one, maybe 2 or 3, that's good, and do a scan for residuals. It's quite nice to have a child-friendly environment as well. So I've got a few tracers up there. They may or may not come out, but the top one is normal. And then you see these other sorts of tracers, such as that, which is typical of a urethral stricture, a fixed outflow resistance. It looks like a box-shaped curve. And then maybe an underactive detrusor, a bladder which doesn't have good muscle contracture, so you're using your abdominal muscles to help empty the bladder. And then really what is a very dangerous, uncoordinated voiding, where there isn't the coordination between the bladder and the external sphincter, which often happens in spinal injury of detrusor sphincter dyssynergia. So urodynamics have been done for a long time by even men with top hats and manometry, but essentially it coordinates by a computer and with radiology the measuring of pressure within the bladder after you've subtracted abdominal pressure. And if I'm correct, most urodynamics lines at Great Ormond Street are inserted under a short general anaesthetic. At the Evelina Children's Hospital, again, many up to the age of 7 are done like that, but in some of the older children, Entonox can be used for line insertion. And again, this should be done in a child-friendly, special dedicated urodynamics suite, which has integration of radiology equipment and computer equipment to get the best outcomes. Urodynamics tracers are complex. I'm not going to take you through them in detail, but essentially allow you to measure the pressure within the bladder after subtracting the abdominal pressure, and then the computer will tell you whether the child has an obstructed or non-obstructed flow, but it also tells you about the filling of the bladder, whether there are unusual and unexpected contractions of the bladder, when really the bladder should just be safe and filling up quite quietly and nice and compliant. So a number of situations can lead to this hostile bladder. Sometimes the bladder has been incomplete or is complex, for example, in cloacal abnormalities. Neuropathic bladders, I've alluded to, are often hostile, as can those be from posterior urethral valves or previous surgery. And in reflux cases, I think you should try and take away the idea that there are probably two types. There's a primary abnormality, which sometimes can occur at the psychourethral junction, which is nothing to do with a hostile bladder, and it's a rare multi-genetic situation. But the picture that I've shown you is a typical hostile bladder up there, tertiary bladder with secondary reflux. And this is a very dangerous situation where you've got a high pressure bladder leading to upper tract reflux there to the native kidneys, and would equally happen to a transplant. And that can be graded to the native system 1 to 5 as per the international system, and that system can be used in transplantation as well. So valves happen about 1 in 5,000 male births. Over the 10 years between that were reviewed at Great Ormond Street, there were about 40 valve patients who were transplanted, and the valve bladder may change over time. The high pressure bladder is unsafe, but occasionally later you get a failure of the detrusor with lower pressures, and things change often in the valve bladder during hormonal changes in these boys, where in adolescence and then in later life, the bladder changes again with hormone involvement. And I think what I'm trying to show on these images are the importance of the interaction between the upper and the lower tract. Because when the bladder empties, the upper tract's no longer empty. Your own ureters are pencil thin, and they empty really by a mechanism which is like peristalsis. But when the ureters are very dilated and they no longer touch each other when the ureter is trying to drain, they don't coact, then they really drain mainly with gravity. And so that there can be problems with the drainage of the upper tract and the lower tract, and it interacts. Furthermore, the obstruction that you can get with valves can happen both at the level of the bladder and ureter junction because of hypertrophy of the bladder as the ureter is entering, but also can happen at the bladder neck due to hypertrophy of the muscle at the junction between the bladder and the urethra. And finally, don't always think that upper tracts which are dilated need to go in the bin. These upper tracts can often be used to augment a bladder very safely using ureter, which has a number of advantages compared to bowel, as we'll see in a moment. So in terms of assessment, I hope that this is relatively clear. We need to be able to assess for obstruction, reflux, infection, and stones. And then, if there has already been a diversion, you really do need to look at that, image it, and look inside it. The bladder itself should be assessed for infection, stones, and the outflow tract for strictures or narrowings. And then the general aspects of the child need to be thought of in terms of the hands and eyes. Could they do future self-catheterization if needed? And as Francis alluded to, the shape of the child can be important, particularly when you're thinking about doing some forms of urinary diversion. So there are a number of key publications from Guy's and from Great Ormond Street, from the Evelyn and from Great Ormond Street. And I would suggest that you later go and have a read of some of these, a little bit of homework to read. But these papers really show that it's possible to do transplantation in children with poor lower urinary tracts with good outcomes. But the question still is when best to do an augmentation, before or after transplantation. So let's just look to see what a bladder augmentation often involves. It often involves using a segment of small bowel, an enterocystoplasty. So the bladder is opened like a clamshell, and the small bowel segment taken in isolation is detubularized and then anastomosed with its blood supply onto the bladder to make it big and stretchy. But there are a number of negative aspects associated with this. You've now got bowel in contact with the urinary tract, so you get mucus, infection, and stones. You can get poor emptying, and the child may need to do self-catheterization. And there are also the potential for abnormalities of the acid-base balance leading to a hyperchloremic metabolic acidosis. So in terms of timing, well, first thing to consider is the age at which the child needs transplant, but also the age at which the child can cope with reconstruction. Now, with very good teams, particularly place specialists and nurse specialists, the younger child may be able to cope with bladder augmentation. But often that is not just the surgery, it's the ability to cope with having to do self-catheterization, or that the carers have to do catheterization, so carer-led catheterization. And this is quite difficult and probably limits a lot of reconstruction to around about the age of 4 or 5, just about going to school. And some of those decisions are quite difficult to make in terms of the social setting. The other area which I'd like you to just think about is the difference between whether the child has this very privileged position that Francis mentioned and Maria mentioned of being able to receive a living donor kidney transplant. Because then a lot of the issues in terms of timing can be really planned for augmentation. But also to think about whether the child has a native urinary tract urine output, what the 24-hour urine output is, particularly with preemptive transplant or the child who's on peritoneal dialysis. Augmenting into a dry bladder where there is no clear timing for the time of transplant, so they might be on the deceased donor waiting list for 2 to 3 years with a dry bladder, is a very difficult situation altogether. And finally, as Francis mentioned about obesity, if you're thinking about just putting a kidney in and bringing the ureter out to the skin, what's called a transplant cutaneous ureterostomy, which is an excellent temporary diversion at times, this is difficult to do in the obese child. So I've just put up this matrix for you. I hope it fits, but I'd be very interested to hear from other centers as to what people think. So if we say under the age of 4 and over the age of 4, and divide also by whether you've got a living donor or deceased donor transplantation, the area where it's most obvious to know what to do is where you're over 4, where you know you can augment, where there's a living donor transplant. You can probably augment a couple of months before transplant, and then everything planned and transplant into that readily augmented bladder. The other areas are more complex. So certainly in the child where there is no living donor, you really probably are thinking about transplanting first, and then having good kidney function, and then undiverting at a later date when the child has either grown or when you are able to then have a native urine output, transplant urine output to put into the now augmented bladder. These are some pictures of what is involved with a Mitrofanoff. I've used that word before. So Mitrofanoff was a surgeon working in Paris, and in 1976 he did this operation for the first time and reported it a couple of years later in French. And he used the appendix with the mesoappendix on its blood supply. He isolated it from the bowel, and he brought one end of the appendix to the bladder and the other end of the appendix to the skin, allowing the child or the carer to catheterize the bladder rather than via the urethra, which is often uncomfortable for the child and something that they don't like to do, but via the abdominal cavity. And this is very well used and accepted by children and adults, and can be done by the child or by carers. It should be continent, using a number of special techniques to allow the bladder to distend, and it sort of closes the anastomosis, and is often beautifully, discreetly hidden into the abdomen, and sometimes the position can be either iliac fossa, the right iliac fossa, or at the umbilicus. Monti, another surgeon, developed this very clever way to make a similar tube out of small bowel segments when the appendix is not available, either because it's too small or scarred, or when it's been taken out. So in final thoughts just about position of the Mitrofanoff, one of the things that really needs a little bit of thought is the coordination between the urologist performing this surgery and the transplant team, such that the positioning of the Mitrofanoff doesn't affect the positioning of future kidney transplants. The Mitrofanoff at the umbilicus is good where the plan is to put a transplant into the iliac fossa, but not good where you're trying to put the midline incision. A right iliac fossa Mitrofanoff is very commonly used, and often then a kidney would be put into the left iliac fossa, but maybe for a second transplant, you then have to think about, can the transplant still go in on the right-hand side? And therefore, ideally, the urologist should not place the Mitrofanoff too laterally, too close to the iliac crest bone, but sort of halfway between the umbilicus and the iliac crest to allow that future extraperitoneal right iliac fossa transplant. So to summarize, these are a number of the aspects which need to be considered. The bladder should be low pressure and stretchy. We need to think about the upper tracts, aspects of the bladder wall which can be dangerous, the neurology, and the outflow tracts, and then some aspects related to continence. Finally, outcomes from transplanting children with complex bladders are good in specific centers doing high volumes with a good integrated transplant nephrology and urology teams. And so in summary, I hope I've been able to cover those topics and happy to answer any questions. Thank you very much.